Okay, can everybody see my PowerPoint slideshow screen? Okay, perfect.
Yes.
Then get into it. Okay, welcome everybody again. Happy to have everyone on for the monthly lab meeting. Updates for this month, we have submitted a few abstracts to both CPDD and ASAM. So hopefully we hear back from them soon. And then we did get a few manuscripts published. Very exciting. Got a couple from a senior lab member, AB, Annabeth. And we got a few new manuscripts in review. One from our senior lab member, Madison Marcus, and then Allison Burster, Michelle Eglovich, and again with Annabeth. Here is our Ivy Lab Twitter, if you haven't followed us already. Our Ivy Lab YouTube channel where we post all of these videos that get recorded every month in case you miss some. And then we have a LinkedIn page as well, which is fairly new. Go ahead and follow us and keep up to date with all of the manuscripts and publications and abstracts and posters that everyone in the lab presents. We also have an Instagram that is up and running. We've gotten a lot more followers and posting, and we're hoping that everyone can be a lot more interactive with the platform. All of which has been monitored and managed by both Arjun and Ira, both lab members. And for studies that we have ongoing, we have CBTIO led by Michelle, which is adapting CBT for people with insomnia and opioid use disorder. We have just pretty much wrapped up the pre-testing phase and are very close to starting recruiting. I think we're going to go ahead and start recruiting this week, actually, which is very exciting. See where that takes us. We also have Project SORT. This is investigating the relationship between sleep and OUD. Recruitment for this study is ongoing. We use some of this data to kind of inspire the CBTIO. And then we also have the registry study, which is an ongoing record that tracks clinical outcomes for pregnant and postpartum patients at OB Motivate. So far, we have 160 participants enrolled. And then we also have Project Castle, which has developed a computerized intervention that educates pre-medical students and medical professionals on substance use disorder stigma. This is now entering the pre-testing phase, which is very exciting. They just submitted a manuscript. And then we also have the educational studies. I just found out that Catherine Henderson is preparing a manuscript using data from a couple years ago and last year, which is very exciting. And then we have some pending research support with all of that going on. Our next lab meeting is to be determined sometime in March, so just keep an eye out for me with info regarding the date and time for that. But if anybody has any questions, don't hesitate to reach out. So that was some quick updates. If anybody has any questions, feel free to speak up or raise your hand. But for the rest of the lab meeting, we have Sajanee presenting some of her work. So I'll give some space for any questions, but if not, Sajanee, you are more than welcome to introduce yourself and a bit about you for everybody on here today.
Hi, everyone. My name is Sajanee. I'm currently a fourth-year medical student at VCU. I'm applying into OB, and we'll find out very soon where I'll be doing residency. Given the free time during fourth year, I've had more time to work on this manuscript that has been in the works since first year med school. So really excited that I've been able to work on it and give this presentation to all of you all. Amber, can I share my screen for the PowerPoint?
Definitely. Do you have, or is it letting you, or do I need to give you?
No, it's letting me. I just wanted to make sure it's fine. Okay.
Yeah, of course. Go ahead. All
Okay.
yours.
Can everyone see my screen?
Yes.
Yes.
Okay. 1 second. I have things pulled up. Okay. Okay, so today I'll be presenting my work on biopsychosocial correlates of insomnia among women and men receiving buprenorphine treatment for opioid use disorder. And I'm going to minimize this. Okay. So a little bit about the background. We're all aware of the opioid crisis with over 5 million individuals in the US being diagnosed with opioid use disorder and overdose deaths increasing to 64% between the years of 2019 to 2022. One of the first line therapies for opioid use disorder is buprenorphine and methadone, and these medications help reduce overdose rates and improve overall health outcomes. Despite advancements in therapy, sleep disturbance is a known barrier to medication opioid use disorder initiation and maintenance, and sleep disturbance can even negatively impact recovery efforts as patients with OUD have reported sleep disturbance as a main contributor to return to use and treatment discontinuation. This intersection of biopsychosocial factors in sleep in individuals with OUD has yet to be fully explored. Utilizing gender-informed approaches in this research is important as women and men face unique psychosocial factors that affect their sleep and OUD recovery. This study aims to compare patient-reported psychosocial factors between individuals with and without insomnia among patients receiving buprenorphine for outpatient OUD treatment. The secondary objective is to examine how gender relates to biopsychosocial factors and insomnia in individuals on buprenorphine. So for the methods and measures, this study is a secondary analysis of a cross-sectional survey and medical record abstraction. The participants were recruited by research assistants who approached eligible patients in the clinic and verified their eligibility and invited them to participate. All participants in the parent study identified as cisgender, so we use the terms women and men to refer to cisgender individuals. For the measures, we used insomnia symptoms, which were assessed by the Insomnia Severity Index. Scores range from 0 to 28, with scores greater than 10, clinically significant for insomnia. For the biopsychosocial factors, we adapted from the FENEX toolkit and used the socio-ecological model of sleep to organize variables into 3 domains, which were individual, family, and social cultural. The individual level, we evaluated psychiatric comorbidities such as depression, anxiety, PTSD, and bipolar disorder, as well as discrimination based on substance use, gender, and race. Family factors included socioeconomic status, health literacy, access to resources, and neighborhood safety, and healthcare access as well. Demographic data was also included, such as insurance status, education, employment, treatment duration, daily buprenorphine dose, and were also collected. And then finally, for the data analysis, we compared participants with and without insomnia, and it was stratified by gender using chi-squared and Fisher's exact tests to identify significant differences. So a little of the demographics here. So 59% of our participants had clinically significant insomnia, with women reporting it 63% of the time and men reporting it 51% of the time. The average age of women in our study was 37.9 years old, with a standard deviation of 9.36 years. And for men, the average age was slightly higher at 43.4, with a standard deviation of 9.5. In terms of race, the majority of our participants identified as white, making up 55.4% of our sample. When it came to employment, nearly half of the participants were unemployed at 46.2%. And regarding insurance status, the vast majority, 86.2%, were enrolled in public insurance programs. So on to the psychosocial characteristics. So some of the key findings of our study, which kind of highlighted differences between men and women with and without insomnia and buprenorphine. For women with insomnia, when looking at individual factors, they were more likely to report PTSD with a p-value at 0.026 and report substance use disorder-related discrimination than those without insomnia. And then for family factors, these women were also more likely to report experiencing discrimination related to their substance use disorder. And beyond these individual factors, women with insomnia were also faced with greater food insecurity with a p-value of 0.029 and more difficulty accessing healthcare with a p-value of 0.039 compared to women without insomnia. For men with insomnia, while similar patterns emerged across individual and family factors, one key difference stood out. Men with insomnia were more likely to report foregoing medical care due to cost with a p-value of 0.023 compared to men without insomnia. And then for our discussion, insomnia is a critical issue for individuals on medications for opioid use disorder, as poor sleep is linked to higher risk of substance use recurrence and reduced quality of life. To better understand these relationships, we applied the social ecological model, which provides a framework for exploring how individual, community, and environmental factors can influence health outcomes. This model allowed us to examine the interplay of factors at multiple levels, from personal experiences to broader structural influences that shape health in individuals with OUD. In our sample of patients on buprenorphine, we noticed notable differences between men and women with and without insomnia. One key finding was that stigma related to substance use was more commonly reported by women with insomnia compared to those without insomnia. Per prior literature, discrimination and stigma are well-documented chronic stressors that can worsen sleep disturbance and exacerbate mental health conditions. For individuals with opioid use disorder, this stigma can act as a significant barrier to treatment, often preventing them from seeking or continuing care due to the fear of judgment. This is especially true for marginalized communities where intersecting identities such as race and socioeconomic status can compound those effects. The cycle of discrimination and avoidance of healthcare services can lead to untreated conditions, including insomnia, further worsening both physical and mental health. These findings highlight the urgent need to address stigma and discrimination as part of comprehensive OUD treatment. Moving on to family factors, we found that women on buprenorphine with insomnia were more likely to report food and transportation barriers, while men were more likely to forego medical care due to costs. These findings align with existing literature, which shows that women often face higher rates of food and transportation insecurity due to economic, social, and cultural factors. For example, low socioeconomic status, caregiving responsibilities, and limited access to education and employment disproportionately affect women's financial stability. These gender challenges highlight the need for targeted interventions that address the unique barriers faced by men and women on medication opioid use disorder therapy. Additionally, further research is needed to explore how men and women with comorbid health conditions experience social determinants of health differently compared to the general population. Lastly, we'll touch on addressing social determinants of health. So it's important to note that psychosocial challenges were reported across all groups of men and women in our study. These findings align with recent research showing that positive social determinants of health like housing stability, education, and financial security are linked with better OUD outcomes. This underscores the need for future interventions targeting sleep or other comorbid conditions in people on MOUD to address upstream factors such as social, economic, and environmental contexts that can influence health outcomes. Our findings also align with the existing literature, which highlights how psychosocial factors contribute to poor sleep quality in patients on medication opioid use disorder therapy, such as buprenorphine. By providing a gender-informed perspective, we've identified unique stressors faced by men and women with OUD and sleep disturbances, paving the way for tailored gender-specific approaches to address these challenges. And lastly, for conclusion, sorry, I'm having struggle. In conclusion, our study found that men and women with OUD and insomnia are more likely to report psychosocial challenges compared to those without insomnia. These findings highlight the critical need to further explore how social determinants of health impact sleep disturbances in people on MOUD. By deepening our understanding of these factors, we can develop a gender-informed perspective that informs the creation of integrative sleep interventions tailored to unique needs of this population. And such interventions have the potential to improve both sleep quality and overall recovery outcomes for individuals with opioid use disorder. And those were my references, and just want to thank Michelle and all of my other co-authors for helping me and putting up with all my drafts that I've given them. So thank you. And I didn't write the question slide, but here's your time for questions.
Great job, Sajanee. Super great. I know that you submitted, so just as a backdrop, this has been submitted for presentation at a national conference, and then also Sajanee and Michelle are about to submit this manuscript for publication. So we are there. We're just waiting on a little bit of feedback from some co-authors. So I'd like to open it up if anyone has any questions or clarifications or anything they found interesting, because then we can incorporate that as we're kind of finishing up the finishing touches on Sajanee and Michelle's manuscript.
I was just curious, and I will definitely see this when I review the manuscript. Were you able to look at how men and women may have reported these insomnia symptoms influencing like their day-to-day lives? And if you saw any differences, any sex differences between that reporting?
I think based off of the survey, I didn't really look closely into like the actual like survey index, but I think some of the questions do address how often they experience insomnia symptoms, but I don't think we kind of analyze to how much per group, if that makes sense.
I can jump in too, because I helped you with these analyses, Sajanee. But yeah, we have for SORT, we definitely have like quality of life, and we also have some questions around daily functioning. We can't really look if insomnia influences like quality of life or daily functioning, because that would require like a fancier like moderation analysis or something that we just don't have the power for. But we could look at some of the daily functioning. There's definitely some of those questions. That's a great point.
Yeah, that's something that I just know sometimes is found to be different between men and women, the reporting of impacts on daily functioning. So that could be a cool addition to look at with people with and without men and women with and without insomnia.
Yeah, and then sometimes even on that, Madison, some other papers when they're doing when they're using some type of social determinants of health framework, sometimes they'll even include quality of life in that. So just as I think that would make sense and not be, super tangential to what their research question was. So that's a good idea. I'm going to pull up your results slide, Sajanee, for us.
I kind of had to break it up into two because it was too big. But did you want to see like the individual factors or the family factors?
I was just looking, I mean, when I made comments on your paper already, so, but, the comments I had said, and it depends on what the reviewers from the journal are going to be interested in, because like just not looking at the p-values and looking at the percentages, I mean, the discrimination indices are, quite more prevalent in the insomnia patients across both men and women. So I think it's good for you to focus on that, especially because in the sleep world, the discrimination and stigma topic has been looked at a lot, and for sleep health in general, but not at the intersection with substance use disorder. So the fact that you had the higher discrimination related to substance use, but this is a sleep is your problem that you're looking at by your independent variable, I think that might be more new compared to what's already kind of been looked at from a sleep perspective. Which is good, right? Because you don't want to you're not trying to claim that people are, it's the same thing sleep researchers have found. So it's always good to confirm findings from other scientists, but then also expand those findings. So I would say the substance use discrimination one across both men and women. I know there's a p-value, but I'm looking at the raw percentages from a descriptive purpose. I think it's going to be the new finding that I don't think any sleep researcher has done that.
Okay,
Mhm.
thank you.
Mhm.
What about the other slide of your results, Sajanee?
This one.
Yeah.
Sorry, let me make this bigger.
Yeah, and something else the reviewers might say, Sajanee, is that again, except for the access to healthcare one, since that one's a little different, the social determinants have and insomnia, no insomnia, that's well established in the sleep world, but again, hasn't been done in the substance use world, which is why your paper is new. A reviewer might, I'm just thinking a little bit, might be interested in how, the differences that you see, the top one, 50% versus 20%, for example, in the women, how does that delta between the people with and without insomnia, is that is that similar to what's been found in other sleep studies, like non-substance use sleep studies? So, we always say there's higher prevalence of social determinants of health, that can challenge people's ability to get the care that they're desiring. Is that difference as prominent as it's been seen in the non-substance use world literature? So that might be something else to look into and add a reference in your discussion. Because if it's a sleep person that's going to be reviewing your paper, they're going to want to know that.
Okay, that makes sense.
Well, just a comment on just how prevalent insomnia is among this our OUD population. I'm just realizing from your numbers and stuff how big of an issue this really is for people with OUD, and it just makes me excited that CBTIO is going to start recruiting soon, and we're going to hopefully implement a behavioral intervention to kind of address all of these barriers. So I think your findings are very interesting, and I'm excited that you're publishing this.
Well, I couldn't have done it without Michelle's help. So, Michelle, thank you so much. And yeah, I feel like the knowing that the CBTIO study is working and like on the like research project is starting is exciting. Just remembering from like my Project Sort days of how many of the women just felt like medications were just not enough to treat their like sleep disorders, like sleep disturbances while getting treated for OUD. So it's exciting.
I'm assuming you did some of the chart abstractions too for SORT. Is that right? Yeah.
Yeah.
That's cool to see this all play out.
I'm just thinking out loud with Dr. Martin's first point about like how this is really interesting, and what sticks out to me the most is that you're seeing that experience of SUD stigma is affecting sleep. And that's really cool. And I was just thinking, if you have like any measures to like correlate, I don't think that there are, Michelle, correct me if I'm wrong, but like it'd be so cool to do, like if you can correlate and like number of stigmatizing encounters with healthcare workers with like severity of insomnia symptoms, or like look in if there's any other papers like pre-post some kind of like anti-stigma intervention in a healthcare setting. Are people's insomnia symptoms improving? I don't know that that literature exists. It could be like great, you know, future directions to put in your discussion as things to suggest. But I think this is I mean, great job presenting, and really cool paper because it opens up a lot of future research questions.
Yeah, I don't know any measures offhand, but I do think it's important to look at like sleep and discrimination, as Dr. Martin has pointed out, has been looked at so much in like a general population, but it hasn't been looked at as much as in this population. And especially with a population that is so at risk of like treatment dropout and like just, you know, the sheer proportion of people with OUD who are like not getting treatment, like any kind of barriers, like can prevent them from getting treatment. And that includes sleep treatment. You know, like Dr. Martin talks with her patients about sleep all of the time. And so it's like not only, and like, so sleep is just like part of some of these treatment concerns, but sleep is such an important part of treatment. So I do think the interactions of sleep and stigma and discrimination in this population really does have such clinical implications.
Anyone else have any other feedback for Sajanee, Michelle? Well, I just want to echo how great it is, Sajanee, for this to go through, because this was the like main preliminary data for us to get the grant for the CBTIO project. So obviously we had the data and then we got the grant and now we're writing it up. So we did a little bit backwards, but it worked. So it's great to see this together. And for the CBTIO project that we're getting off the ground, that this data was formative to, you know, we're not addressing everyone's social determinants and psychosocial factors. Like we're not doing anything about them, you know, just to put, that would be like a full-fledged like intervention. But what we're doing is taking a harm reductionist approach by not pretending they're not there. And so traditionally CBT for insomnia has just been like, you know, just don't drink alcohol or just don't use drugs. Just sleep in a bed that's perfect and with great, you know, it's dark and there's no noise. You know, it's very cut and dry. And obviously, with our patient population, harm reduction is infused throughout all of the care that we do, right? By meeting people where they are. So the cool part about CBTIO is that we are addressing all of these factors that are in your paper, but not to the point where we're trying to fix them, right? Or take them away. Like that would involve that would involve changing society. But we're using a harm reductionist perspective to say, oh, great, I recognize you live in a place where it's not dark, right? Or you maybe don't want it to be super dark in your room at night because you don't feel safe. Okay, well, let's incorporate that into how we can tailor the CBTI practices that we know work, but how can we tailor that to your needs by, again, meeting people where they are? So, which typically is not how things are done in a research protocol. Usually research protocols are very A, B, and C, X, Y, and Z. So, so it's great to see your data just reflective of the work that Michelle has been leading on, adapting CBTI for this patient population with all of these variables that you're presenting in your paper, as kind of the numbers and the data to drive the adaptations. Well, great job. Great. Well, if no one else has anything else, I'll just say great job, Sajanee. Super great work. We're looking forward to getting the paper submitted soon. And you have some good feedback from today to incorporate into your discussion. Last changes to that before you submit.
Well, thank you everyone for your time and listening and all the feedback.
Yeah.
Great work, Sajanee.
Thanks.
Thank you everyone for coming. We'll see you next month.